Dr. Chang is the UCSF Neurosurgery Network Director of Quality. She's the director of the UCSF Neuro-Oncology Gordon Murray Caregiver Program and the co-director of the Sherry Sobrato Brain Cancer Survivorship Program. Dr. Chang is an internationally recognized leader in the field of neurological malignancies. Dr. Chang?
Thank you so much, Lacey, for that introduction. I wasn't expecting such a detailed introduction. So it's really great to see everyone here tonight. It's really an honor to be here with all of you. And really during this exciting and what I would consider a paradigm shifting and transformative time in the treatment of brain tumors. So the Sherry Sobrato Brain Cancer Survivorship Program is really proud to sponsor today's webinar. We really continue our commitment to being at the forefront of patient care and support. And our program is dedicated to addressing the unique needs of all of our patients, including our young adults. And I think that's particularly relevant for this webinar today. And we want to constantly evolve to serve you better. So at UCSF, while we're advancing research and exploring new therapies, this is a main focus for what we want to do. We also want to prioritize what our patients tell us and also what is most important to them. So we've always, with these webinars, integrated the patient voice. This is such a powerful part of what we do in terms of hearing what the experience is for the patient. And that's why we try to work to integrate their perspectives into everything that we do. So by weaving their experiences into our educational materials and care strategies, we really try to make this work in a way that really matters to everyone. So I'm so fortunate and so pleased that Linton Daniel is here with us today. He really embodies the spirit of patient involvement. He has been an invaluable member of our survivorship program. He serves as a peer volunteer since its inception and contributes his insights on various patient education review committees. And his dedication and perspective have really enriched our community, and we're deeply grateful for his continued involvement. And now it's my great pleasure to introduce our featured speaker, UCSF neuro-oncologist, Dr. Jenny Taylor, or JT. She has been with us as a faculty member. She reminded us today of now 10 years, which is fantastic. And she serves with me as the co-director of our neuro-oncology supportive care services. And she specializes in the care of adults with primary brain tumors and really is a leader in groundbreaking research aimed at improving patient outcomes, especially things like cognitive health. And she's particularly focused on enhancing quality of life for both patients and caregivers. Is involved in novel treatment strategies, advancing imaging techniques, and doing comprehensive molecular profiling to better understand and combat resistance to treatments. So we're really fortunate to have her here today to share her insights in conjunction with Linton. And so I'd like to introduce Jenny Taylor. Thank you.
Thank you so much, Dr. Chang. Let me get us situated here. All right, hopefully that looks okay. Well, again, thank you all so much. I can see we're almost at 80 participants today, and I think that your enthusiasm about this new drug and how it is that's going to change, I think, the future and the lives of patients living with IDH mutant gliomas. I echo that enthusiasm. I think, as Dr. Chang mentioned, I've this week embarking on my 10th year as a neuro-oncologist, and I will always remember August of 2024 as a day that the life of all of those who are caring for patients with brain tumors also changed. So we're going to do kind of a bit of a 30,000-foot view. As was mentioned, we'll leave the questions towards the end, and I hope very much to have plenty of time to address questions, and thank you to our moderators for helping field the questions. I'm privileged to have Linton on with us. I'm also privileged to be Linton's neuro-oncologist. So we have been on this journey together for several years as well. So let's go ahead and get started. So Voranigo is the name of this drug, and you'll hear it kind of interspersed throughout the presentation using its brand name, Voranigo from the company Servier, as well as Vorasidenib, which is the generic term. So just in case that's a little bit confusing, we're going to kind of interchange, I'll probably accidentally interchange those terms. And so we're going to talk a little bit about what it is, what it does, and what it means for you as someone living with an IDH mutant glioma or the loved one of someone living with an IDH mutant glioma. So a few disclosures. I have received grant funding from Servier as well as served on an advisory board of Servier. This presentation is by no means vetted by Servier and there's no conflict to my opinion, but certainly important for everyone to know, as well as some additional grant funding. So I wanted everybody to be sure that we're all starting off on the same page. So we're going to talk a little bit about what Voranigo is and the science about how it works. This will be the majority of the talk. I think it's important as we look towards the future to know how we got there. We'll interweave Linton's perspective throughout these different subsets as well. We're also going to talk a little bit about how to take Voranigo and the possible side effects and challenges that are going to be a bit new to us in the neuro-oncology community. And so I think, again, that transparency is important. There are some unknowns and future opportunities. While this is incredibly groundbreaking and very exciting, not all of our questions have been answered. And so I think as you all are embarking with us in this new realm, it's important for us all to know what we don't know. And where we need to still get questions answered. And then at the end, we'll certainly be sure that, and please, as we go along here, to put questions into the chat. So we have plenty of opportunity for questions and answers for myself, Dr. Chang, and Linton and the team. So let's get started. So what is Voranigo and the science behind how it works? So these are 4 of my brain tumor patients that I've taken care of over the course of the last 10 years. All of these individuals are in their 40s. All of them are parents. All of them are in the prime of their life, having careers, embarking on all kinds of different aspects and avenues within life. They all live in California. And they all presented with something a little bit different. Headaches, seizures, some kind of little bit of confusion, memory. And they all had these sort of distinct, different radiologic findings. So this is an axial or sort of a cross-sectional view of the brain. You've probably looked at these types of pictures with your neuro-oncologist, and the circles are the areas where we think the tumor is. And it probably is kind of relatively straightforward to see that some of these are very discrete lesions that may be able to come out. You sort of can draw a circle around them and be able to remove them. And some of these are much more hazy and diffuse. And you can imagine trying to take a lot of this out probably takes out a lot of healthy brain as well. And I think that these are a range of different MRI features as we meet with patients early on in their journey. So this is kind of how things started off at the beginning. So all of these patients went on to receive surgery, and all of these patients were found to have an IDH mutation in their glioma. All different corners of the brain, if you will. And so don't worry, we're not going to spend too much time under the microscope and the pathology, but as it comes across how excited we are about sort of this new place, I think in the context of where it is that we've been and the ambiguity and gray zone that we've been living in, is really an important thing, I think, for people for patients to also kind of understand and grapple with. And so the WHO is the World Health Organization. It's sort of how we brand gliomas, if you will. And for many, many, many years, actually, probably still the majority of my career, as early as it is, we mostly were using the 2007 WHO classification. And what this really did was we took the tumor sample out. You would look at it under the microscope. You would sort of see if it kind of looked a little bit like an oligodendroglioma or a little bit more like an astrocytoma. Of course, surgical centers with more pathologists who have a lot more experience are able to kind of distinguish these things a little bit better. But at the same time, it's somewhat ambiguous, as you can see. And the grade of grade 2 and 3 and then 4 was also somewhat subjective. So picking out the number of cells that were undergoing division, picking out the number of cells that seemed to be generating more blood vessels. And so depending on the size of the sample and where it is that the tumor was taken out, and therefore the pathologist who was examining it, there was a lot of variability in how these tumors were defined. Even back in 2007, there was a mashup tumor, an oligoastrocytoma, where it was thought that maybe oligodendroglioma cells and astrocyte cells both potentially formed tumors together. And so this really created and set up a lot of variability in how it is that people were treated with these grade 2 versus 3 tumors. And glioblastoma does not harbor the IDH mutation, and we're not going to talk about it very much today. But again, just sort of a focus of, as we increase in size, increase in number, that the aggressiveness of the tumor also increases. And then in 2009, it was discovered, this IDH mutation. And so don't worry, we're also not going to spend a lot of time in like biochemistry and the Krebs cycle, if you remember the Krebs cycle from your high school biology class, but this is where this mutation comes from. And so isocitrate dehydrogenase is what IDH stands for. And what it normally does is produces this alpha ketoglutarate, which is here in this particular slide. And so what normally isocitrate gets converted to alpha ketoglutarate by IDH1 or IDH2. However, if you have this mutation, an IDH1 or an IDH2 mutation, instead of generating this alpha ketoglutarate, you end up generating 2-hydroxyglutarate. And what we've learned since 2009, that this is something that creates tumors. It's oncogenic. It creates disruption of the DNA and the environment of the tumor. It makes it more hypoxic, and it is a driving function for patients who have this IDH mutation. And we don't know what causes the mutation. We don't know how long it takes for these tumors to develop. We think probably a couple years, but the logistics of that are not really well known. But this is a functional, really critical mutation. And what we saw is there are patients in grade 2 and 3, sort of these lower grade, slower growing tumors, that 80% of them seemed to have this IDH mutation. And people with glioblastomas or grade 4 tumors, only about 5% of them seem to have this IDH mutation. So it was also something that you could see really easily under the microscope, and it was kind of black and white. The brown stain here, the tumor cells. So you take the slide and you sort of put this antibody to stain for the IDH mutation. So if the brown, this is on some sort of weird timer. I apologize for that. So if this brown cells come back as positive, and you can see then these are blood vessels, so they're blue, which means they're not positive for the mutation, then you know that you have an IDH positive tumor cell. And so this is a very homogeneous. So regardless of how small your sample size, your sample of your tumor, you can potentially identify this. And so this was really a very novel, important way of identifying these tumors early on in the diagnosis, even right after the microscope. So a lot of times now, within a week, we sort of know the answer of whether or not the IDH mutation is there. And we're going to look at these curves a couple times today, so I'm just going to spend a moment. This is called a Kaplan-Meier curve. And on the y-axis here is sort of our percentages. So, and the x-axis is time. So at the beginning of this journey, 100% of people at 0 time, so time of their tumor diagnosis, are alive. And as you go over time, you see that these curves decrease, some of them very steeply, some of them a little bit more in a stutter step over time. And these are based on the 2007, so the way we used to classify these tumors. And you can kind of, my point in showing you this is that it's all sort of a mess. Like there's the orange group that's down here, the glioblastoma, but the 2s and the 3s and the oligodendrogliomas and the astrocytomas and the mashup oligoastrocytomas, it's all just sort of mixed together. And this really reflects how we've been treating patients. Some people with grade 2 tumors don't necessarily do as well. Some people with grade 3 tumors seem to live for decades. So it really mirrored the clinical experience. However, when you add in IDH mutation, you start to see a little bit more separation and clear delineation of who it is. So if you don't have this IDH mutation, then these are patients who have glioblastoma, unfortunately have sort of sprinting through their clinical, a lot of them are sprinting through their clinical course where things sort of happen very quickly. But then you have the blue and the purple here, which are people who have the IDH mutation in this 1p19q code deletion, which is essentially now known to be an oligodendroglioma. And those people's, their curve is it's a slower curve. So people are living longer, many people even decades. And then you have sort of this in between where where mostly it's astrocytomas, but you still have this IDH mutation. So it really helped kind of create this sort of mess. And by knowing whether or not a patient has an IDH mutation, regardless of how it looks under the microscope of grade 2, grade 3, oligo, astro, it really helped us sort of clarify the patient journey. And so this really updated in 2016, so that's 8 years ago now, how it is that we classified tumors. So the WHO, the World Health Organization, said, okay, in order for you to define a tumor, a brain tumor, you have to know its IDH mutation status. And then in 2021, so just a few years ago, they really did a big overhaul and revamp and said, okay, now you absolutely have to know the IDH status. You also have to know this 1p19q, which again is something that we see in oligodendrogliomas. And then for patients who had grade 4 tumors, or what used to be called an IDH mutant glioblastoma, essentially now only patients without that IDH mutation. Now there's many other tumors in the brain. There's 100 types of tumors in the brain. Many of those don't have an IDH mutation and they are not glioblastomas. But for the purpose of this talk, these astrocytomas, if they have the IDH mutation, they can be grade 2, 3, or 4. So now instead of having an IDH mutant glioblastoma, you have an astrocytoma IDH mutation grade 4. An oligodendroglioma is either graded grade 2 or grade 3. And essentially a glioblastoma cannot have an IDH mutation anymore. And so that really helps us understand, as we think about therapeutic targets for patients who have glioblastomas versus patients who have an IDH mutation, that we're really thinking about these illnesses differently, that whatever caused this tumor, how it might respond to different treatments. While there may be some overlap, they're also very different, and we probably need to be thinking about them differently. And so again, for taking kind of all of that, those messy overlapping curves, and trying to create a little bit more separation over time. So for patients who have an IDH mutation up until August 6th, this is really how we've been thinking about these tumors. So you had a tumor, you took it out, you determined whether or not it had a mutation, the IDH mutation. If it had the IDH mutation and it was a 1p19q co-deleted tumor, and we're not going to spend too much time on that today, then you knew that it was an oligodendroglioma, and then you would rely on your pathologist to sort of see, does it look like it's growing slowly? Does it look like it's growing mediumly? And that would help us kind of grade these tumors on a score of either 2 or 3. Now, if you had this IDH mutation and you did not have this 1p19q co-deletion, which means that it's intact or normal, then that was an astrocytoma, and you would either be able to grade it, again, slow growing, not a lot of cell division as a grade 2, or if it seemed like it was moderately dividing or dividing more quickly, then you would grade it on a score of 3 or 4. And so depending on what this tumor was and how much the surgeons were able to take out and how the patient was doing after surgery, there's all of these different options. And really most of our clinical trial data is looking at radiation and chemotherapy. And I'm sure many of you have had discussions with your neuro-oncologist. Maybe many of you have received radiation and chemotherapy, but this has been the gold standard. We know radiation is helpful. We know adding chemotherapy to radiation is helpful, pretty much regardless of which one of these tumor types that you have. Sometimes people who have all of their tumor removed and are just going to be followed. Sorry. Jeez. Stealing my thunder. Then those tumors might just be monitored closely. And again, many of you have probably been on this trajectory. There may be some small examples where we would think about a chemotherapy alone for a certain subset of tumors, but there's really a lot of choices, and it can be very difficult to make these decisions as the clinician, and of course, with you as the patient. I think people who have these IDH mutated tumors really are running a marathon. They may live decades with their tumor, and we know that decades of living with something after radiation, for some people, not all people, but can have slow impact on their cognition, ability to work, help take care of their families, live the high, thrive, with the quality of life that they wish to have. And so trying to avoid or trying to time radiation correctly has always been something that neuro-oncologists have been interested in doing. And however, that is really where most of our data is. And so those sort of living in those two different worlds has been a very difficult place for me and all the patients that I've cared for over the last 10 years. But there is a new dawn. And so knowing about this IDH mutation, which remember, we learned about in 2009, and here we are in 2024, now with a drug that actually targets this IDH mutation. That sort of gives you an instance of how long it takes for science to move things forward. And hopefully things won't take quite as long to keep it moving forward, but there's still an immense amount to learn. I think when we talk about these treatments, this is not a cure. And so as we continue to improve quality of life and help our patients live longer and better, we still need to be looking for more and better options, and helping people live even longer and longer. So what is this new dawn about? So kind of going back to this discussion about what the mutation itself is. So it produces this 2-hydroxyglutarate. And again, that's an oncometabolite that actually we know it's an early event. So it happens in all of the tumor cells, and it seems to happen really early on whenever these tumors develop. And it creates cell division and growth. And this is also a mutation that exists in a couple of other tumor types. So patients who have a subset of leukemia actually have this IDH mutation in their blood cells, or patients who have gallbladder cancer, cholangiocarcinomas also have this IDH mutation in their gallbladder tumors. Now, that doesn't mean that brain tumor patients are at risk of leukemia or at risk of gallbladder cancer. These are just common ways for the tumor cells to hijack this system and exploit it for inappropriate growth. What's interesting to note about those things, though, is that they're much more common than oligodendrogliomas and astrocytomas. And so there were drugs that were developed for leukemia that were targeting this IDH mutation, because that was also found in about 2009 or so. And again, given the much more commonality and being able to do clinical trials more quickly for something that's more common like leukemia, there were approved drugs for these IDH mutations. So these are IDH inhibitors that are known to decrease 2-hydroxyglutarate and therefore slow down or even regress the growth of the tumor. And the first one that we knew about is called Vorasidenib. And again, this may be a drug that some of you are on. This may be a drug that's something that your neuro-oncologists have spoken with you about. And what's interesting, so it's a pill, it's a daily pill, and it was approved in acute myeloid leukemia, AML, several years ago. And it targets a subset of these IDH mutations. This IDH1 R132H is 80% of all tumors in gliomas that harbor an IDH mutation have this particular mutation. And so, really smart neuro-oncologists around the country said, well, if this seems to be really helping leukemia patients, and we know that this mutation exists in brain tumor patients, let's give it a try and see how patients do. It's a very well-tolerated medication, especially compared to radiation and chemotherapy, as you'll hear more about. And so what they did is here on the right side, these are called waterfall plots, and neuro-oncologists like to look at waterfall plots a lot. So again, here on the y-axis is percent. So above the line is growth. So something is increasing in size. Something below the line is decreasing in size. And these are MRI scans. And these are non-enhancing tumors, so very similar to those original 4 patients that I showed you, slow-growing non-enhancing tumors. And the blue shows that there are a subset of patients who received this drug who seem to have progressive disease fairly quickly. And then many of these patients had stable disease, so a tumor that was growing stabilized, which is pretty exciting. And then even a few of them seemed to actually decrease in size. However, if you looked at tumors that had enhancement, and the 4 patients I showed you did not have any enhancing tumor, but enhancement is sort of a marker of those higher grades. Grade 3 and grade 4 astrocytomas, oligodendrogliomas tend to also be enhancing. And so you can see that most of those patients didn't really seem to respond to ivosidenib. And ivosidenib, the brand name of that is Tibsovo, just in case that's something that many of you are more familiar with. And so while some patients did actually stabilize for prolonged periods of time and even partially respond, many of these patients actually ended up progressing fairly quickly. And here's that Kaplan-Meier curve again. So here at the beginning, 100% of people are alive at time 0. And over time, you can see that people with enhancing tumors didn't seem to do very well, which mirrors very much what we saw in their MRI. But these non-enhancing tumors, and these were people with recurrent IDH mutant tumors. So they may have had radiation, they may have had chemotherapy, but it seemed to be that we slowed things down. So this is progression-free survival. So how long are you stabilizing the tumor? And this number, 13.6 months, isn't overly exciting, I know, but certainly a lot longer than 1.4 months. And again, in a tumor that's growing, is certainly and it's a signal. It's something encouraging. So there are a couple of these other IDH inhibitors. Enasidenib focuses on the IDH2, which is about 10% or so of all IDH mutations. And then vorasidenib, or now known as Voranigo, actually inhibits all of these mutations. So it's a pan-IDH inhibitor. And so knowing that there was some preclinical work to suggest that this was well tolerated, mice tumors were slowing down, decreasing 2-hydroxyglutarate in their tumor. And so this is what they used to sort of move forward in comparison with ivosidenib with our next trial. And so this is a trial that you'll hear a little bit more about, but this is really a well-designed study. And so what this did was take some patients who either received vorasidenib or ivosidenib, not blinded, all of whom had a known IDH mutation. So again, these are people with recurrent tumors whose tumors were growing. And what they did was some of these patients actually didn't receive any treatment. Some of them received different doses of the vorasidenib, and some of them received different doses of the ivosidenib. All of these patients needed to have another surgery. So all of them received 1 month of one of these treatments, and then patients who didn't receive treatment before surgery went on to receive one of these treatments after surgery. And what they did is then took the tumor sample out and see if you could actually decrease the 2-hydroxyglutarate. So everyone was exposed to one of these different doses of the medication, and then they could measure to see if the 2-hydroxyglutarate or the effect of the medication just after 1 month seemed to actually work. And so these are the controls. So these are people who didn't have IDH mutation. So maybe they're glioblastomas, or maybe there's some other type of brain tumor, but they didn't have any 2-hydroxyglutarate. That's not surprising. These are some controlled samples from a different cohort of patients that showed that you have a lot of 2-hydroxyglutarate, which again, you would expect in someone who hadn't received an IDH mutant inhibitor. And then the patients who then received no drug before their tumor surgery didn't really have any change, again, expected. But you can see here in the vorasidenib at the 50 milligrams, which is what ends up translating into the 40 milligrams that was approved, you see this dramatic drop in the bar. So the box collapses to below detection, maybe not all the way down to the IDH wild type levels, but certainly a dramatic improvement. And you see maybe not quite so much at a lower dose of the vorasidenib, much movement. In the ivosidenib, you do see some decrease, but there's a bit more of a spread. And then when you look at the effectiveness, those waterfall plots and things for patients, then you also, again, saw some really encouraging signs. So these are those waterfall plots. All the blue is the vorasidenib and the green are the ivosidenib. And again, most of these patients, so these were non-enhancing grade 2 tumors, they actually decreased in size. So even if you got 10 milligrams, and even if you didn't necessarily see that much decrease after 1 month in the tumor sample, you still had an MRI response afterwards. And you also saw that in ivosidenib as well. And this is called a swimmer's plot. So if you can think of, we just finished the Olympics, so we should all be kind of can think about the swimming in the Olympics. So everyone is in their own lane and everyone's starting here at time 0 and then going along over time. And you can see a lot of blue, a lot of blue, a lot of green, a lot of green, a very long, stable disease with patients who had recurrent tumors. So this, again, very well tolerated medication, really encouraging results. And so this is what led then to the development of this INDIGO study, which is what the results of which landed us the FDA approval for Voranigo. So now we're taking patients with newly diagnosed. So none of these patients have had radiation. None of these patients have received any other type of chemotherapy. They've only had surgery. And those patients were then, they had surgery either at least a year ago, but no more than 5 years ago. So their MRI scans, you kind of had a sense of stability and you knew sort of a little what was probably scar tissue from surgery versus what was probably tumor. And these patients were randomized and blinded either to receive Voranigo at 40 milligrams daily or a placebo. And the doctors didn't know and the patients didn't know. And everyone went on to receive MRI scans every 3 months. At some point, if there was concern about the tumor growing, then the doctor who was seeing the patient would sort of raise a flag, and the MRI scans were reviewed centrally. So not by the radiologist, which is very different from institution to institution, but by sort of a central, like everyone, two people who were looking at all the MRI scans. And if they agreed, then the patient was unblinded. So then the doctor knows and the patient knows if they've been getting the vorasidenib or the placebo. If the patients had received vorasidenib, then the worry is that it wasn't working and they needed to go on to some other different type of treatment. Sort of, that was a conversation between the doctor and the patient. But if they were receiving placebo, they were given the opportunity to cross over and start receiving vorasidenib. And remember, IDH mutant tumors often will be stable and growth can be controlled for several, like up to a couple decades. And so waiting to see if we actually improve survival, overall survival with these different techniques, the science is going to move along much, much, much faster. That's sort of this paradigm we've been living in over the last several years. So what they did was based on those MRI findings, they said, okay, well, can we stabilize these tumors? Can we stall their progression longer in patients who received the Voranigo versus those who received the placebo? So that was the primary outcome. And then the secondary outcome was time to new intervention. So essentially, how much change is enough change on the MRI scan to say, yes, we need, in fact, to do something different. It's not just watching it, but actually doing something different. And this is a very clinically relevant endpoint. They, of course, are capturing overall survival data, which we don't have those results of yet, and will be very complicated when we actually end up getting those results. And they're measuring quality of life, cognition, and seizure control. So a lot of things that are really important to you as IDH mutant tumors. So we were really excited about the drug and also excited about what the design of this trial and what it was going to teach us about how this medication works. And so these are the results. So again, Kaplan-Meier curve, I told you we would be looking at these a few times. So everyone starts at the beginning, 100% of people are alive. And so the red is the vorasidenib, again, a slower curve. The blue is the placebo. And so the patients, this study these interim results were released in March, or actually published in June of 2023. So it took us a year from when we knew this medication worked to actually getting it approved by the FDA. And what it essentially translates into is a 61% reduced risk of disease progression or death. And that really is pretty amazing. Now, this progression is defined by the MRIs, and this is central. So this is not the doctors and how the doctors feel like they're doing with each individual patients. These were people who were centrally blinded to these two different arms, but who were consistently measuring the MRIs together over and over and over again to help with consistency. These are different odds ratios and hazard ratios. We don't necessarily need to spend too much time on the details, and I know the numbers are tiny, but what you really want to just mostly focus on is essentially if the bar is to the left, it means vorasidenib seemed to patients who had these different subtypes, either based on their age or based on their gender, based on how long they were from surgery. If the little box and lines go to the left, that means vorasidenib was better. So patients who tolerated vorasidenib seemed to improve more than on the placebo towards the right. So in the middle is equal. So if everything was right along the line, it means there would be no difference between vorasidenib and the placebo. But what you can see here for the vast majority of all of these different subsets, however you slice and dice this data, people with vorasidenib do seem to do better. Similarly, when we look at that outcome of time to next intervention, which again is how much change is enough change to say, like, let's do something different. And this is more clinical. This is really not the radiologist's interpretation, but this is the doctor's interpretation of how an individual patient is doing. For the vorasidenib, which again is that red line, it's really flattened out, and a lot of it is not reached. And I know personally, I have several patients who are still receiving vorasidenib on this trial who are doing well for quite some time, versus those with placebo who have grown. And I think what this has also taught us, and Dr. Sean Hervey-Jumper, who's one of our neurosurgeons, highlighted to me at one of our conferences where we discussed this together, that even though people are getting placebo, I think a lot of these tumors are stable, they are definitely growing slowly over time. And so I think as we have these new options and new treatments, we'll be thinking about doing treatment earlier than waiting, because the side effects of these medications versus another surgery or radiation sort of favor a little bit more of earlier treatment. And so this is a 74% reduction of the risk of receiving the next intervention. So 74% risk of needing to do something else. And this is for the patients who all started the race, if you will, started the clinical trial, either getting the vorasidenib or the placebo. This data does not really highlight the patients who were on placebo who then crossed over to the vorasidenib. So these are what's called the intention to treat analysis, or sort of what, how everyone was assigned at the very beginning. And again, as we look at all these different subsets and slice and dice up the data, everyone seems to be towards the left as far as this outcome for people who really do, the majority of patients, well, oligos, astros, again, everyone here is grade 2, but an oligodendroglioma, an astrocytoma, number of previous surgeries, location of the tumor, all the different ways we can look at the data favors the vorasidenib. And so this is what led to the FDA approval on August 6th. And so with that, I'm going to turn this over, and we've done a couple of videos, and thank you, Linton, for doing this, about his experience and walking through being part of a clinical trial and being part of these particular clinical trials. So he was on the vorasidenib trial, the second one I talked about, where they gave everybody drug for about a month before surgery and then took out the tumor sample to see if the 2-hydroxyglutarate actually decreased. As has already been mentioned, he's one of the first cohorts to participate in the neuro-oncology peer-to-peer volunteer support groups here at UCSF since 2020. And he's also founder of Expert Patient in service to the brain cancer community worldwide. And this is Linton at our Vancouver Society for Neuro-Oncology meeting with several of his compatriots just this past November. So I'm going to hopefully let this video play.
I had a recurrence of my tumor after I was taken off my first chemotherapeutic agent in mid-2018. And my tumor was growing by leaps and bounds. And so in August, I met with Dr. Taylor with my family, and I asked what my options were. And she said, well, we're going to have to resect your tumor again, because I couldn't get, Dr. Berg couldn't get more than 2/3 of it out. So I was looking at that again, and my options after that would be radiation, which we've been trying to avoid. I'd made the conscious decision to avoid that, along with Dr. Taylor and Dr. Berger, and then to be on to Itimodar, and I didn't want to do that. And she said, well, there's a possibility you might be able to take Vorasidenib, a new agent. So you have to start doing that immediately. And we'll operate on you exactly 28 days later. And if the tumor shows response to this new targeted therapy, we'll keep you on it as long as it works. And so that's how that happened. And I had to go in immediately on a protocol. My understanding was there were only about 25 people on the planet who were on that drug, chemotherapeutic agent. And I'm one of the few survivors of that original phase 1. And it was rigorous, shall we say. We'll talk
Yes,
about
being
that.
a part of a clinical trial is always rigorous, and we are so grateful to all of our patients who have had who have the opportunity to participate in a clinical trial, and their commitment is really we couldn't do this without them. Okay, so how to take it and possible side effects and challenges. So Voranigo is a 40 milligram tablet. It comes in 40 milligrams and 10 milligram tablets. 40 milligrams, I think, are for those who are 12 years or older. So there weren't a lot of kids in this particular study, in the INDIGO study that got it FDA approved. And so there's more interest in that. And some of those children, based on, of course, like their weight and things, may need a smaller dose. But it's a daily pill. And you'll hear again from Linton sort of how it is that he's chosen to take the pill. Since we've learned a lot more, some of the flexibility about taking the medication has been a little bit easier. But as we were learning with, the first early phases of the trial, we really kept everything homogeneous and really wanted to be very stringent in how it is that we were analyzing this. I think one of the biggest challenges that we're going to have as a neuro-oncology community is that this is an open-ended daily medication. And radiation may last 5 weeks or 6 weeks. Chemotherapy like temozolomide might last a year. Chemotherapy like procarbazine and CCNU might last 9 months. And so we sort of know when the end is in sight. And that's not true for this Voranigo. We don't really know how long patients need to be on it. And it ends up being it's really open-ended to see how things are going. Of course, safety first, and then obviously and we'll talk about some of the side effects, but also as it relates to the benefits. I think this medication also seems to take some time to work. It's not necessarily like radiation or some other chemotherapies. Is it a chemotherapy? It's a good question. I think it depends on how you define that. I think we consider it a targeted agent, but it does require lab work. For the first 2 months, we need blood work every 2 weeks, and we'll talk about why that is in a few minutes here. And then for essentially the open-ended amount of time, you need blood work about every month. So it's laborious to have to go to the lab every month for an open-ended amount of time. Maybe a little over time, maybe we'll need to do that less often, but for now, that's what's being recommended for at least the first 2 years. And then MRI scans. So, needing to check in, see if the medication's actually working, assessing the seizures to see if the seizures are getting better or getting worse. And whether there's a response on the MRI. It does seem like these tumors, some people do benefit from shrinkage. So some people's tumors have actually decreased over time and stabilized. But again, this is not something that we think at this point is a cure. So we definitely have to continue to monitor things. And work together with your neuro-oncologist about how long to stay on these medications, how long to wait to see if this medicine's going to work. We do think that this medicine doesn't work for everyone. And so how long do you sort of make those determinations? There's a lot of questions that we still have that are unanswered. So I'm going to turn it back over to Linton and let him sort of highlight a bit some of his the side effects of the medication, and we'll go into a little bit more detail.
My family were not happy with my decision to take the Vorasidenib every day at noon. But the reason I did that was to try to get some rigor into how I was incorporating Vorasidenib into my life. I wanted to make sure I did it every single day at the same time, noon. So I never veered from not eating or drinking anything for at least 2 hours before noon. So that's before 10 o'clock in the morning, and not at least an hour after, according to the protocol, after noon, which is 1 o'clock in the afternoon. However, I didn't feel like eating anyway. After taking Vorasidenib, there was no way in the world I was going to eat. So oftentimes I would just simply take a nap until I became habituated to it. It definitely had an effect on me. There's no question about that. But it was nothing like the drug that I've been taking earlier. Nowhere near as difficult to me on my my gut or I didn't have mouth sores, nothing like that. So it's much easier. I would say that based on what I've seen since the approval of the drug by the FDA, I'm starting my 6th year on Vorasidenib next month. I've been subject to all the side effects. So yeah, sudden upsets, diarrhea, all kinds of things. So for example, on diarrhea, I learned to modify what you might imagine, my food intake. No spicy foods, no alcohol. Now that was absolutely forbidden by the protocol. If I had a headache, Advil was prohibited, things like that. So I learned to modify my diet. But just as much as that, getting proper sleep, exercise were so important. And as you know, we worked on a project at UCSF, Living Well with Cancer, cognitive strategies. And I put into effect many of those kinds of things. And I took my situation as my experience as a project. And that's another thing that I was taught at UCSF through Dr. Christina Lawaya-Jamora. Come to terms with the fact that I needed to completely change my life to make sure this thing worked. Rigorously following the protocol, never missing a day. I missed one day in 5 years, close to 2,000 doses right now, because I drove off on a trip and it would have been 5 hours or something to drive back to get it. And so I thought, oh, well, okay, I've done everything perfectly. So the side effects are more in the head, getting used to the idea that this is what's keeping me alive. And I really strongly believe that.
So
You know,
So just a couple little things. So with this, in the context of this study, we were a bit more rigorous about the timing of the medication on an empty stomach or not. The FDA indication, actually, you can take it with or without food. It just, as Linton mentions, needs to be at the same time every day. So, very consistent. There's not an interaction that we're aware of, and it's not an FDA contraindication for alcohol use. But obviously that's something that needs to be monitored. And then the compliance, I think, is something that we're all very worried about. Taking some of these other chemotherapy agents, 1 week a month or a few days every 6 weeks or so, it was very different than taking a daily medication. And many of you probably do take anti-seizure medication, and those are medications that you take daily, or there's a lot of other medications in your life that you take daily. But I think the importance of how these medications work in the context of that compliant rigorousness is really going to be something that we're going to have to, figure out how to manage. There are some drug interactions, and I do think that's an important thing to highlight, as Linton mentioned, with things like Aleve and Advil and some medications. So we'll come back to that. But really, the biggest side effect that is pretty consistent, again, regardless of any of these subsets, is the liver. And unlike most of the other chemotherapies we use, where we more are worried about the blood count, so immune system getting low or the platelets getting low, this really does seem to have an effect on the liver. And so there's, for that purpose, for the first 2 months on treatment, that you need to assess every 2 weeks the liver tests as well as the rest of the blood counts. And then over time, if you aren't seeing those effects, then you can check the levels a little less often. Some patients may need to have these medications held because their liver tests are getting high. Some patients may need to have their medication reduced, the dose of it reduced. And that's fortunately why it also comes in those little 10 milligram tablets and not just the 40 milligrams, because you're not supposed to cut it or crush it. Fortunately, what they have saw in the clinical trial is that most of these liver effects were reversible. So you held the medication and things sort of got better on its own. But this is definitely something, as we start using this in a lot more different types of people who are on a lot more different types of medications, it's going to be something that we have to monitor very closely. COVID-19, this clinical trial was actually all conducted during COVID-19, but it doesn't necessarily, this drug doesn't increase the risk of COVID-19. As Linton mentioned, some diarrhea, some headache, fatigue. I think as is true with so many of these medications, even seizure medications, it takes a little bit of time to get used to these medicines, but these are pretty common side effects that we saw even in the placebo arm, and are pretty consistent with other seizure medications or other side effects of other medications. So hopefully things that can be managed over time. But really the liver tests are one of the major concerns. So again, the hepatotoxicity, so you have to kind of monitor very closely for the liver. Thinking about drug-drug interactions, there are some particular pathways that are through the liver that can interact with the vorasidenib. I think actually Paxlovid, for example, with COVID is actually one of those medications where you have a drug-drug interaction. So be sure that as you're thinking about medications, new medicines, over-the-counter medications, supplements, all of these things really need to be discussed with your neuro-oncologist. There's also drug-drug interactions with some, not a lot, but some seizure medications too. So these are really things that need to be very well laid out and discussed with your neuro-oncologist. And some tobacco actually may have an effect on the benefit, or too much of the medication may actually end up in the system in use with tobacco. So that's actually in the FDA label, is that you shouldn't be, you recommend non-smoking. So it's important to consider. And then I think one of our biggest challenges is going to be as it relates to family planning. And again, these are patients just like those 4 patients I mentioned at the beginning, parents, young parents, early in their careers, and sort of trying to figure out how to navigate this open-ended medication in people who are often in the time of their life where they may be thinking about continuing their families. And this is a medicine that does seem to decrease the effectiveness of hormonal contraceptives, so birth control. So that's going to be something that really needs to be discussed with your neuro-oncologist. There are mouse, we don't have any human experience with the effect of this medication on a fetus or a baby, but we do have animal studies that show that it does seem to be that there's embryo-fetal toxicity. So miscarriages and early effects, effects of the growth and stuff like that. So it's really carrying a child and being on this medication is not going to be something, and it's going to be something we really have to think about, and of course have to plan for. It may affect fertility. So with temozolomide, for example, as a medication that once we often get it out of the system, then people are able to have healthy families thereafter. That may not be the case necessarily in this medication, and so this may have an impact sort of longer term, even if you come off of the medication for men and women. And so again, kind of making sure that discussions about fertility preservation before you're starting treatment, and thinking about alternative ways to conceive families are going to be a part of this journey. And Servier does have some resources on their website that may be helpful, but this is really going to be something that we're going to need to learn a lot about as neuro-oncologists, because this is not something we've necessarily needed to journey with to date. And then breastfeeding is also not recommended. And so for getting pregnant, the current recommendation is that you don't try to get pregnant, obviously, while you're on the medication, or for at least 3 months after you stop the medication. And then similarly for breastfeeding, no breastfeeding while you're on the medication for at least 2 months after the medication. And so these are, again, really big grappling challenges that we're going to have to figure out how to live with, and managing when the right time is for these medications going forward. So I'm going to let Linton talk a little bit more about some of the positive effects.
Well, positive changes, of course, is that this is nothing. This targeted therapy is nothing like the chemotherapeutic agent that I was on before, the first one. So this was really a positive change. I think mentally I am in a much better situation than I was when I was in comparison to when I was taking everolimus, my first chemo. I haven't had radiation, of course. That's another thing. That's enormous. I think my overall health is better than I could ever imagine. And it's not just physical, it's mental. I belong to a support group, a peer-to-peer support group at UCSF, which has been absolutely instrumental in getting me out of my shell and making me realize that this drug has given me a new lease on life. My Dr. Patero made it very clear that I didn't have many options right before I started on Vorasidenib, and I'm really glad that the opportunity came along, that I was able to be pretty much the last person to join that first phase 1 trial. So I'm doing much, much better than I could ever imagine 5 years ago. And I really reclaimed a sense of independence, which I didn't have at all when I was on my first chemo, where I was completely obliterated by all the physical effects and the mental effects and the chemo brain. This drug does not have the chemo brain effect. It has it, of course, after I take the pill. So this teeny little pill, which we take every day, which is incredibly expensive. Hopefully it won't be all that much for everyone, but here's my pill container. That's my lifeline. And I think mentally, it's just as important. The encouragement that I'm getting somewhere, that this agent seems to be working. It's working on me. I'm still here. Has been self-reinforcing. So I'm very, very grateful to that, to the drug company, Servier, and to UCSF, my team.
So I think the FDA was really a bit more generous in their indication. So most of those INDIGO studies that I talked about before really were these grade 2 tumors, at least a year after surgery, no more than 5 years after surgery, non-enhancing tumors, no prior treatments. The FDA was a bit more generous in who it is that they're allowing on this trial. I actually today got approval for a patient with a grade 3 oligodendroglioma who'd only has had surgery. So I think we're learning a lot about who this medication is going to get approved by the FDA for and who it really is going to benefit. But we're going to be able to sort of answer some of those questions in reality, as opposed to sort of waiting for clinical trials. So there are ongoing clinical trials, and we'll talk about that as well. But I think Linton did a great job of highlighting sort of the mind shift of what's needed to really benefit from these medications. And we're so fortunate at UCSF, as we're hoping to help people live longer, that we have additional resources, the Thrivers group, mental health support, cognitive support, wonderful social workers, really such an umbrella of supportive care that we can offer patients as they're continuing to not only think about how to take this medication every day and check their liver tests and get their MRIs, but also how to live during all of that and thrive. And so some of the unknowns and future opportunities. So these early phase studies are sort of where we have clear data. These red boxes are where we really don't have clear data. And whether there's a role for people who have a tumor that's in a really difficult location and surgery, even by the amazing neurosurgeons at UCSF, is risky. Is there a place for that, for these drugs even before you have surgery? What if it's something that's incidentally discovered? Does that make sense to start somebody on a drug even before doing a surgery in and of itself? And how can we actually find that IDH mutation if it's not necessarily in the tumor and having to go through brain surgery? Is there a blood sample or some other MRI characteristic that we can non-invasively find this IDH mutation without having to do a brain surgery? What about people who are like a month out from brain surgery, or people who are 20 years out from their first brain surgery? How are those people going to do with tumors? What about those who have grade 3 tumors, or those who have enhancing disease, or those who've had radiation and chemotherapy? I mean, the FDA has allowed us to get some of these answers, but again, as we figure out the timing and what this means for you as you come here and talk to your neuro-oncologist about about this medication. You know, again, there's a lot that we don't know. What we do seem to receive from feedback from the insurance companies is using it in combination with something like temozolomide or other chemotherapies is not something that they're going to be approving right now. We don't have any safety information about whether that's safe. And so that's something we're going to need to do research on and understand better. But again, treatment at recurrence, or maybe even for people who've had radiation and chemotherapy and have had a really good response and everything is stable, do we put all those people on vorasidenib or Voranigo as well? What about people who've been on Tibsovo or ivosidenib for years and years and years with stable disease? Do we switch those people all to vorasidenib? And then again, the combination of treatments, I think, is really, so a lot of unknowns, we'll learn more about this. And I think what's really important is we don't actually know that this drug is going to help people live longer, like actually increase the number of years that they're going to live. We're using this MRI essentially as the surrogate marker, but we don't actually know that this is going to extend people's lives. And it's going to take a long time for us to actually get that answer. Because of the design of being able to cross over from the placebo to the vorasidenib, it may be really hard to get those answers. So this is not a clinical trial where we've compared it to what we've known to always be helpful, radiation chemotherapy. You know, that's not what this is. This is this is sort of paving a new path, and it's really difficult to compare it to the historical prior paths. The company has still done a very good job of assessing quality of life, assessing quantitatively impact on seizures, and also cognitive outcomes. So patients who are on the INDIGO are getting cognitive assessments to see if it seems to sort of stabilize cognition or maybe even improve cognition over time. So how that translates into you as an individual patient, if you're not on the INDIGO study, you know, I think we have a lot of questions to be answered, but again, a lot of resources at UCSF to help along those ways. One particular clinical trial that we do have currently open at UCSF is for patients who have progressive grade 3 tumors or enhancing tumors. Maybe those are grade 2s, but more likely probably to be grade 3 tumors. And so similar to that original design in the study that Linton was involved in, patients are receiving an immunotherapy. Pembrolizumab is an immunotherapy. You're sort of unleashing the immune system in combination with the Voranigo. So some patients are just getting Voranigo. Some patients are getting Voranigo plus an immune therapy, which is this is called Keytruda, is the brand name of pembrolizumab, or aren't receiving any treatment. And then all those patients go on to get surgery. So again, you're getting the actual surgical sample, seeing the impact of the 2-hydroxyglutarate, seeing what the immune system actually does in the tumor sample itself. And then everyone goes on to receive the combination of vorasidenib and Keytruda after the surgery. So everyone's getting the same treatment going forward, oral daily Voranigo, and then the Pembro or Keytruda is given once every 3 weeks. And so regardless of whether or not you had the drug or any of the drugs before the surgery, everybody gets the drug after the surgery. So this is ongoing. I think maybe they recruit 15 patients, something in that time. We're participating here at UCSF. Dr. Jennifer Clark is our principal investigator here. So this may be an opportunity for us to look at some investigative combination therapy and also a disease where we're maybe a little bit more worried that the Voranigo alone may not cut it. So, and I'm doing pretty good on time. So I'm going to let Linton sort of bring us home here, and then we're getting close to being able to open up for questions.
I would say, having gone through a rigorous protocol, phase 1, 5+ years, almost 5 full years, starting my 6th year, adhere to the protocol, so to speak, comply with the directions that you're given by your physician. I would never shortcut myself, and I'd recommend all patients who are on this drug, and there are going to be tens of thousands of us, not to cut corners. The other thing is that long term, I think many of us are going to be surgically resected. We're going to have an operation. We're going to go straight to this drug. And that's absolutely revolutionary. But in order to give us ourselves as a group, those of us who are going to be taking us or are taking us, the best possible chance to be tracked and to understand what's going on with this drug long term. We have to give ourselves the best possible chance, as I keep saying, so that we can be tracked and we can honestly say we've done everything by the book. The other thing is long term. This is a therapy, and the pressure is not going to be reduced on the families and the loved ones of those people who are taking this drug. It's really, really important, in my opinion, for patients like myself, believe me, I've tried, to reach out to family and say, please avail yourself of the opportunities for the support that you obviously need, in my opinion, to deal with me and to get the support you need for a person who has long-term illness. This brain cancer is not going to go away. I mean, I'm assuming that if this drug fails, this therapy, my tumor will still kill me. That sounds pretty cruel, but I've been living with that for 13 years, expecting, oh my gosh, what happens with the next MRI? I've had 67 MRIs. That's a lot. And it's always very nice to hear Dr. Taylor saying it's stable, appears to be stable. But I know that for many of my fellow patients out there, sometimes the answer is it's growing. And I've been in that situation, of course. So I encourage you to get involved with support groups. Encourage you, if you possibly can, to get your family involved in support groups for themselves, and then have fruitful and honest discussions with your neuro-oncologist about how to help your family and yourself.
So well said. So, I think Linton really highlights something. Your neuro-oncologist may use the word tumor and cancer somewhat interchangeably, and I do the same. This isn't really a chemo, but it is a targeted agent, and it does require, or it seems like we need a long amount of time on this medication. So it's a very strange thing to sort of receive the news that this is a low grade, good tumor, but you're going to need to be on a medication long term for it. And so I think there's a lot of support at UCSF that can kind of help. No one knows what you're going through more than your peers. And I think we can help with some of our facilitators, many of whom are on the call tonight. And then, of course, talking to your neuro-oncologists, peer support. And then I think, Linton also mentioned the caregiver. I think this is also something, figuring out how to be on this medication, all the monitoring that's required, as well as sort of the cognitive effects and the changes in your lives, also from the caregiver that your partner may have as well. And so again, we have resources at UCSF to try to help along those ways. Our team is growing. We actually just have 2 new neurosurgeons and 2 new neuro-oncologists that have just joined us, and within like the last few weeks. So I haven't even this slide will be significantly updated the next time that I give this talk. But to all of our neuro-oncologists, our incredible neurosurgeons, and then our neurocognitive team, we're all here for you, and we're so privileged to help take care of you and to really enter into this new phase of how to treat patients with brain tumors and giving people more options. So with that, I will thank you so much for your attention, and thank you so much, Linton, for your contributions and wisdom. And I will stop sharing and see if we have any questions in the chat.
Thank you, JT. Yes, we have questions. So
Okay.
Really appreciate the detailed and really clear presentation, both your perspective and then, of course, Linton's perspective as a patient. So thank you both so much. So one of the questions that was asked is, most of these tumors, as you know, for the INDIGO trial was with grade 2. You did mention about grade 3 oligo, you getting sort of approval for that. So one of the questions that came up was, is this going to work for grade 3 oligos? And what about grade 4 astros?
Yes, thank you, Dr. Chang. So I think for grade 4 astros, if you remember those sort of messy curves, I think we still worry that people who have faster growing tumors may still need something like radiation and chemotherapy. I do hope that there are clinical trials that will be adding in Voranigo for those patients. But I think for my practice right now, for a grade 4 astrocytoma, I would be worried about starting with Voranigo, regardless of FDA sort of indication. I think the grade 3, you didn't ask about grade 3 astros, I think are hard. I think it really sort of depends about how much tumor is left behind. I mean, again, I think it takes a time for these drugs to work. And so if we've got, again, even our incredible surgeons, just the location of the tumor, it's one of those really hazy, fuzzy ones that it's really difficult to take out. I think for some grade 3 tumors, the Voranigo may not have enough time to sort of work. I think if the tumor all came out, or what the neurosurgeons were able to remove safely, and there's really very little that we can see, I think those are discussions. So I think there's going to be a lot of discussions about what to do and where Voranigo sort of falls into in those areas. So I'm glad. I was surprised today actually to learn that I had a grade 3 approved, and I received information from another neuro-oncologist that they also received approval. So I think it'll kind of depend, and we'll learn as we go.
Thank you. So another question that's come up is, what about patients who've had prior treatments? So there's a situation where someone received procarbazine and CCNU for 36 months, and then now for 36 weeks. And now the question is, would that patient be a candidate for Vora? Should there be changes on the scan that suggest progression? Similarly, another patient with an oligo grade 2 who had radiation and chemotherapy in the past. So would these two patients, for example, at the time of progression, be able to receive Vorasidenib?
Yeah, I think there are a couple of different clarifying points to that question. So one is you do go on Vora after completing those treatments, for example, just for like maintenance. I think that's an interesting conversation to have. And then I think if there's whether the insurance will allow us to get access to the drug, which I think will change over time, but is something that we can't even order this medication in the computer yet. It's so new. But I do think that the FDA has allowed us to try to answer these questions in real time without having clinical trial data. So I think it may be, and I'm trying to get Vorasidenib approved for patients who've had radiation and temozolomide, for example. And I think some other patients or some of my colleagues have had some success in getting it approved. So I do think we'll have the opportunity. Whether it works, I think, is really a different question. And probably how I guess I'm thinking about this is a little bit of that rate of change. If this is a slow growing tumor and it's maybe changed over a year or two, and there's not uncontrolled symptoms, we would discuss this at our multidisciplinary tumor board. We're not here to put our neurosurgeons out of business. We're not here to put our radiation oncologists out of business. There's still very much roles for those treatments. And so I think we would discuss as a group to see if this made sense for Voranigo to be our next step. But at least the FDA has sort of given us some leeway in potentially giving patients the drug and are not sort of preventing us from potentially giving access. I think it'll be a case-by-case basis, but I'm hopeful, and I don't think this drug's going to work for everyone, and we don't know what is there something inherent in the tumor biology that sort of predicts whether someone's going to respond, yes, no? Is there something about, what are the mechanisms of resistance that develop over time that create progression after someone's been on the drug for some time? These are people who are then going to start with Voranigo and end up getting surgery, radiation, chemo. Is the response going to be as good there as you would have expected? So again, these are things we really don't have answers to right now. But more options are always good.
Yeah. Thank you. So one other question about starting treatment. There's a situation where a patient had surgery 3 years ago, gross total resection, scans are rock solid stable. And now they're being told, you need to start vorasidenib. What would you say to that patient and family?
Yeah, I think it's a conversation to have. Everyone in the INDIGO study had measurable tumor. So everybody had something where we could follow on the MRI scan. Our surgeons are wonderful at taking everything out completely and getting gross total resection. So we can't really see anything on the MRI except for the expected scar tissue. And you're committing somebody to a medication that maybe they would need to be on for a really long time. And it's not that it has zero risks. I think the family planning piece is an incredibly important aspect of that conversation. And I think it really depends. I don't know that it's wrong, but I don't know that it has to be the case. I'm not planning on putting all of my patients on Voranigo just because they've had this type of tumor. I have a patient who had surgery within the last 3 or 4 months who had a grade 2 oligo resected 20 years ago and has had no other treatment. So are we really, I mean, that's the natural history, I think, of some of these diseases. So I think it really, but we can't predict it at the beginning. So it's a conversation. What would you say, Dr. Chang? How would you discuss that question?
Well, as you said, I think I've had patients where they've had a really good resection. There's no disease that we can follow. And I'm not sure that's a situation that I would start this treatment because there isn't anything to see whether it's getting bigger or smaller. You have nothing. So I think it doesn't hurt to follow those patients closely and then decide when you see a change, maybe that's when you start. But because that's not this indication that INDIGO was used. So I agree with you that you could be subjecting to a patient to many years of treatment without knowing what the benefit truly is.
Right.
So that's one of the things. There is a couple of questions about tolerability. And Linton, you talked a little about diarrhea. So somebody is asking if they have like irritable bowel disease or Crohn's disease, a liver disease, like a fatty liver, does that mean that they shouldn't be on this drug?
No, I don't think there's any contraindications to the FDA. Again, some of the drug interactions, I think that's something to really be worried about. But I think these things just will need to be very closely monitored. I personally, and I've probably given this drug to maybe like close to a dozen patients, haven't had uncontrolled diarrhea, nausea. I think, but for some people, I think they're more vulnerable to that for sure. But I think it's been something we've been able to manage. And maybe reductions in dose and things along those lines might be appropriate. Fatty liver specifically, I think while there may be evidence of fatty liver, doesn't necessarily mean that the liver isn't working the way that it's supposed to. So I think those things, just as I mentioned, you'll have to really follow the hepatic toxicity, the liver toxicity closely, and it may need to be dose reduced, but it's not necessarily something, if the liver tests look good going in, that you would say that, no, we can't try.
Yeah, thank you. So there's also some questions about accessibility of vorasidenib. So one of the questions is, one person asked if they're on disability, would they still be able to get the drug? I don't know, maybe Lacey, you could help us with that question. And the other question is, for somebody who's on the sort of expanded access through Servier, what happens to those patients? Can they now get it without having to go through the expanded access?
Good question. I'll let you start, Lacey.
Well, disability is not an insurance. Disability may indicate if you've been on SSDI for 2 years that you have Medicare, but in and of itself, disability is not an insurance, so shouldn't impact it. And it depends on the combination of insurances. Let's say if you did have SSDI for 2 years and you do have Medicare, do you also have Medi-Cal? And so that may impact it, but I'm not certain. I don't know. I haven't had any experience in it as yet. I'm happy to help anyone who has questions, and I can partner up with Dr. Taylor to get the best information we can for them at the time.
Thank you, Lacey. Yeah, I agree. I don't think that being on disability in and of itself would preclude access. I think it'll depend a little bit on the insurance. And we've already seen, as is, I'm sure everyone on this call is familiar with, not all insurances are created equal. So there is variability. I will say that Servier has really been very thoughtful and very much wants to be a partner in this and helping patients get access to not have insurance be the overwhelming barrier. So they have, I think, some templated appeal letters and things along those lines. And I think over time that this may change. I would also just say, use the opportunity to say that Tibsovo or ivosidenib, the leukemia-related drug that we've been using off-roading with for several years, we don't really have problems getting access to that. So there may be alternatives while we're waiting to see if Voranigo is approved in certain situations or gains FDA approval in certain situations, that we may have other options depending on the IDH, the subtype of the IDH mutation. And then, sorry, Dr. Chang, what was the second part of your question?
Well, that was mainly it.
The expanded access.
Yes.
So I think for patients who are on the expanded access, I think we're still waiting to hear for the patients who are on the clinical trial, or clinical trials we're also still waiting to hear. I think they've been a little busy in getting everything up and running at Servier. But again, they're really a great partner. Their website, and maybe I'll see if I can find it and put it in the chat. Their patient-facing website is really very wonderful. They realize that we as neuro-oncologists, I mean, this is the first drug. I mean, Dr. Chang, 2005, I mean, was the last time that a drug for brain tumors was approved by the FDA. So the majority of people who are practicing neuro-oncology have never been through this before, of having a new drug and how to get our patients access to it. And so Servier, I think, really knows that based on their partnerships with other neuro-oncologists around the world. And so I think they're helping us navigate this, and then, of course, helping you as the patient navigate this too. So they've been a very good partner in all of this thus far. So I would certainly, I think they're pretty accessible, being able to get more information. And I'll put their patient-related website here in the chat for everyone.
So there's a question. You talked about, getting this maybe out beyond the United States. So there's actually someone from Brisbane. I have no idea what time it is there, guys, but thank you so much for participating. But they're asking about, in this particular question, it's a little bit complicated because there's a detailed history of prior treatments, and they're currently on a trial with selinexor. And they were just wondering, they have an oligo, I believe. And they're just wondering, does this mean then they should just stop what they're doing and get on vorasidenib?
Yeah, I wouldn't recommend that. I think if something is working and it seems like it's safe, I don't know that again, there's a lot of questions that we don't know the answer to. This is not going to be the right medication forever for everyone. And so I think I'm from the South, so if it ain't broke, don't fix it sort of thing. If something's working, I don't know that I would pivot to something that we don't know if it's going to be a good indication. But I think I view it more as an option, something in addition to think about if something different does need to change. I will also say that I have I helped write a paper with a colleague in France, and they're still waiting to receive, their version of the FDA indication, and it may be different than what the FDA has approved in the United States. And so I think depending on where you live, it might also, access may be a little bit varied from place to place, which isn't uncommon, but I think is something to take. So everything we've talked about today is very United States based, but is not necessarily worldwide.
So another question that came up was about concurrent medications. So if you're on a seizure medicine, for example, is there some interaction that you have to worry about? Is it a type of seizure medicine you shouldn't be taking?
Yeah, there are a couple of the CYPs that are CYPs, which are certain pathways common pathways that drugs get metabolized through the liver, that are potentially interactions. off the top of I think there are ones that they're more older ones that we don't use quite as much. So more newer ones like Keppra, for example, Lamictal, Vimpat. Those are all brand names that many patients are on, at least many of my patients are on, that maybe are okay, but certainly and your pharmacist, the pharmacist that's prescribing the Voranigo as well, will also be sort of double checking those things. So it certainly is important to make sure that the drugs that you're on, supplements or even over-the-counter medications, that there's a lot of disclosure and conversation with your neuro-oncologist or your whoever's going to prescribe the Voranigo. I think that's also something that we're interested to see, whether this ends up being other neurologists who are managing your seizures. Maybe they're also prescribing your Voranigo. Maybe there's your oncologist if you live in a place where you don't have access to a neuro-oncologist. So I think it'll be interesting to see who ends up prescribing this medication over time as well.
Great. And then a couple last questions. I mean, I think we could go on and on, right? But one of the questions was about COVID. Is there an increased risk of COVID if you take this medicine? Is there anything that you need to be worried about because you're taking it?
Yes. So I do think I think Paxlovid actually has an interaction with Vorasidenib. So I think if you're on Paxlovid, you would maybe need to hold the Vorasidenib. As an example, don't do that before talking to your neuro-oncologist or your prescribing physicians for sure. But I think that's just something to be on the lookout for. But no, in and of itself, it doesn't seem to increase the risk of COVID. Or this is not a medicine like other chemotherapies that lowers your immune system. So we certainly will monitor for that, but that's not a very high risk. We, of course, would recommend getting your updated COVID shot and your updated flu shot if you haven't had any contraindication to those in the past. But I do think, as all patients who have seizures may know, high fevers and things and getting really sick can increase your chance of having a seizure. So I think that would be something, just given the population, that be on the lookout for, but specifically not with COVID. And so if you do get sick or if you go on a different, like an antibiotic may also be a medication that would have potential interactions with the Voranigo. So if you need to go on any other medications, just be sure you let your neuro-oncologist know and pharmacist to be sure it's safe to stay on both.
And, one of the questions that came up is why focus on IDH1 and ADH2? And of course, the more common tumor is glioblastoma or grade 4, IDH wild type tumors. So where's the future for targeted therapy for glioblastoma, do you think?
Yeah, such a great question. I mean, I think that this is a sign of hope, I think, across all different types of brain tumors. I think you just have to find what the target is. And glioblastoma multiforme, the M is multiforme, which means it has multiple mutations. And while many patients who have IDH mutations have other mutations, it's not quite as prevalent around the tumor as the IDH mutation. And so I think we haven't found that version of the IDH mutation in glioblastoma. So it's a bit more of a whack-a-mole problem, and you knock down EGFR, for example, or CDK2, whatever, and then something else sort of, a clone kind of pops up. So please know that I know I see some glioblastoma patients here on the call. There's a lot of research, actually a lot more research going into glioblastoma than IDH mutant tumors. It's just I think it's just a harder nut to crack. And Dr. Chang, as somebody who's been, doing research in all of this space for decades, I would say, your wisdom, I think, in answering that question would also be greatly appreciated.
Yeah, no, I think you're absolutely right. There's certainly a lot more challenges with treating glioblastoma, as we all know, not only because of the difficulty with multiple pathways and different genetic abnormalities that are within the tumor. You all know about getting drugs into the tumor as well in the brain is very different than some other cancers in the body. And so making sure that the drug gets in the right concentration and does what it's supposed to do. I think that's been a challenge with a lot of the targeted therapies we've used is does it really get in? And if you know from Dr. Taylor's presentation, a lot of the work and what Linton went through, right, was to take the drug before surgery. So this way that we can actually sample the tissue and see how much drug is actually in the tumor. Did it block the mutation? Did it suppress the downstream effects of it? And those types of studies are going to be much more powerful for us to understand, which treatments are the best treatments to do. So I think many more of those types of trials are coming along. Whether it's done as a treatment and surgery or treatment with a biomarker, for example, imaging or blood biomarker, I mean, that would be the goal. That would be fantastic, that we don't have to put patients through surgeries all the time to get this answer. But until that time, I think those are going to be the main challenges that we face with grade 4 tumors, unfortunately. I see someone else from Australia join us, and they're telling me it's 1:30 on Thursday. So that's great. Maybe Linton, do you have any final words? And a lot of questions were related to the treatment itself and so forth, but we really value your input. Just maybe some last words before we close everything up.
No, I thank you very much for everyone on this call, not only tuning in, but also the team that have been supporting me all these years. Actually, I was quite somewhat inaccurate. I've now been on Vorasidenib for 6 years. I'm starting my 7th year in a couple of weeks. And so I would just like to say that this has been a very humbling experience. I would not say it was humiliating, and there's a huge difference between those two words. I think that I would claim, anyway, I've tried to accept a high degree of personal responsibility for my own health in association with the wonderful people who have helped care for me at UCSF. And without that combination, I think I'd be still flailing. And I think what Dr. Taylor mentioned, and you mentioned, Dr. Chang, is the most important thing is to have an in-depth conversation with your neuro-oncologist, if you're lucky enough to have one, and figure out what the best course is for you. Because in the final analysis, we have this targeted therapy, but it's going to have an individual effect. And my commentations were anecdotal. It's just one person. But as time goes by, we'll find out much more about the class of people who treat this drug. So thank you very much for including me in this evening.
No, thank you so much. I think it's hard to know because there's so many of you on, which is wonderful. I don't know if you're all at UCSF or not, but we want to make sure that you are aware that we can review your records. We can provide an opinion. We can talk with you about, options as well. Not that I'm saying that your own oncologist can't do that, but we're just here for you. So if that would be something that would give you peace of mind, that would give you some comfort in understanding the information, because it is all new, as Dr. Taylor said. So if that's something that you would like us to do, please reach out to us. We'd be happy to set up, a video call or a second opinion or clinic visit, whatever works for you as well. So with that, I think I actually think I got to most people's questions. So really, thank you so much, Dr. Taylor and Linton. I really want to thank also Naomi and Lacey and Joni for being here and for giving us the opportunity to sort of hijack their group to have this. But we really thought this was going to be important for everyone who's currently dealing with this type of tumor, and it is very exciting. So I appreciate everybody's attention. The videos would be available in a few weeks, and we look forward to seeing you all again. But thank you very much.
Thank you all. Take good care.
Thank you. Take care.
Thank you so much, everyone.